Welcome to IVAC's World Immunization Week webinar series. To kick us off, we have Dr. Noor Barzev, Deputy Director and Director of Epidemiology at IVAC. Before we get started, I want to let participants know that we will have a short Q&A session at the end, so please enter your questions into the chat box, and we will get to them after the presentation. Any questions we do not address, we can follow up individually with after the webinar. This webinar will be recorded, and thank you for attending. I'll now hand it off to Dr. Noor Barzev to introduce IVAC in today's presentation.
Thanks, Andrew. So hello, everybody, and welcome to the third in our series of webinars for World Immunization Week based here at IVAC. For those who've heard me present the first couple of slides before, bear with me. There are varying audiences every day. So just very briefly, who are we at IVAC? IVAC is an academic centre at the Johns Hopkins Bloomberg School of Public Health. Our aim, really, our mission at IVAC is to accelerate the access to life-saving vaccines through the development and implementation of evidence-based policies. And we try to both to generate and to synthesize the evidence, to do it in a way that informs policy and to support countries to implement policy that increases access to life-saving vaccines. We do that across a range of practice areas, and we have expertise in a large number of particular infections. Next slide, please, Anne. We were founded in 2009. Since then, we've expanded really to a global presence with partners all over the world, and we have about 50 faculty and staff, and quite a large number of graduates as well who've gone on and done other things at a very high level across the world. This week is World Immunization Week, and we've been really trying to focus on areas that are either current challenges or being challenged through the COVID-19 pandemic that we're facing. We have 2 sessions remaining. Today's session, which I'll come to in a moment, and tomorrow's session, which is also a very important one, on how to protect existing vaccine programs in the era of COVID-19. That will be presented by Dr. Anita Shed and Professor Bill Moss. But today we have a fantastic session, which is going to be led by Lois Preventable. Lois has been with IVAC since before IVAC was even IVAC, really from the very beginning. She leads she's the Director of Policy Advocacy team and at IVAC. She really has been involved from the very beginning in advocacy and in policy making at a regional level and a global level, and supported the building of capacity in low and middle-income countries with a strong focus on India, but also working further afield regarding policy research and advocacy for immunizations across the life course. And in particular around adult vaccination, which is an area that she's developed very strongly, both within IVAC and internationally, where she has established the International Council on Adult Immunization. Fantastic experience to bring to bear, particularly in the COVID setting, where, as we know, so much impact is being had among adults. So without further ado, please, Lois, welcome to give your talk.
Great. Thank you, Noor, and thank you to everybody for attending. I'm Lois Preventable, and I'm very happy to be here to talk about adult immunization in the context of COVID. And I'm joined by my colleague, Prab Vasudevan, who helped to conduct a lot of the research that I'll be talking about today. We're very interested in hearing a lot of your questions, so I'm going to go through some of this relatively quickly. But older adults are a population that are particularly important because they're hardest hit by COVID. We currently don't have a vaccine, but if you fast forward a year or two when we might have a vaccine, and that's a vaccine beyond emergency use that we're very hopeful that we'll get something soon, we need to ask the question, are we ready for adult vaccines? And can we take advantage of the vaccines that we have today? Next slide. So today I'm going to be talking about 3 key areas. One is what is the importance of adult immunization? Then I'll talk about the research that we've gone into, which includes our archetypes research, which I also refer to as typologies. And then we're going to go into strategies for deploying a COVID-19 vaccine. Next slide, please. So if you look at the vaccines, there's 3 key vaccines that we really focus on when we're talking about adult immunization. So these 3 vaccines include influenza vaccine, pneumococcal vaccines, and herpes zoster vaccines. These vaccines are all available today, but they are underutilized. And it's important to note that the impact of those vaccines goes beyond the diseases that they prevent, and I'll talk about that shortly. So if you look at why we vaccinate older adults, most of us think about, we're doing it because we want to reduce deaths due to the vaccine preventable disease, and we also want to reduce hospitalizations. Yesterday, my colleagues Victoria and Alex explained during the Voice webinar that there are many benefits beyond these initial health benefits, and that's what I want to talk about for just a moment. Next slide, please. So vaccines for older adults do have a broader health, economic, and social benefit. And on Monday, Brian Patnaud and Libby Watts explained that generally the economic benefits for vaccines are strongest in children because they're accruing over a lifetime. But there's economic benefits that are also recognized, that should also be recognized for adults. We don't normally capture some of those economic benefits, but those are important. It's important to recognize that other generations, including volunteer contributions or contributing to younger generations' ability to go to work, are also economic benefits. Or when people have a sick parent, that actually affects the economy as a whole because it affects productivity as a whole. So it's that interconnectedness that needs to be considered. The other thing is also talking about functional ability, and that's defined as the ability to do things that we value. So when people come ill from a vaccine preventable disease, they may be less able to do the things that they value and become more dependent on others or unable to care for themselves, and others need to help them with that care. And that's a concept that not only impacts the adult themselves, but it affects everybody around them. So the idea here in the COVID context is that the more healthy somebody is in the face of COVID, the greater the likelihood that they will recover and have fewer severe effects. Next slide, please. So I show that here in this slide. So we start off with a person that maybe has some underlying health issues. Sorry for the slides. Can you go back a little bit? Thanks. So we start off with somebody that has underlying health issues. Next, click. So if a person is immunized against influenza, it is still possible that they get some type of effects from influenza, but they're generally short and they're generally people will generally recover. So that's with the blue line there. But if you look at the orange line, click, the effect for a person that's unimmunized will be a lot greater. So they're going to have a lot more severe effects from that bout of influenza, and they may not end up recovering to the level that they had recovered before. And this is particularly important when we're considering the context of COVID, because if somebody is not at the highest health status that they could be, they run the risk of having worse outcomes than they would if they were otherwise recovered. Next slide. So we know that by immunizing adults with the vaccines that we had mentioned earlier, that has some big benefits. The question is, are older adults actually being immunized? And this is where our research comes in to take a look at this. Next slide. So if you look at this first slide, what it shows is that just nearly 40% of countries even offer the recommended flu vaccines to countries. And that number is much lower if you consider pneumococcal and herpes zoster vaccines. Click. So if you look at it on a country basis, so this was a study that we looked at for 34 high and middle income countries. And we looked at those countries mainly because that's where vaccines are being given in public programs. Unfortunately, there's not a lot of public programs for the broader adult population in low and middle income countries. You'll see here with the orange that there's a number of countries, there's a few countries that give multiple vaccines. So like the US, Australia, and some of the European countries. But there's also a number of countries that really only give influenza vaccines or give no vaccines at all. And those are represented by the lighter blue or the gray countries. Next slide. So why are existing adult vaccines so crucial for COVID? Just as a quick recap, it's to reduce disease, but we're also concerned about reducing the utilization of hospitals and the resources that might be needed when we do face COVID-19 cases. We want to also reduce the underlying disease, which contributes to the severe outcomes of COVID, and prepare for implementation of a vaccine. So if we have platforms where countries are used to giving vaccines and people are going to get vaccines, that's important, because when a vaccine does arrive, we'll have more experience to know how to do it. The other point, and the last point I think we can't forget, is that strong childhood programs also have an impact on adults. So if kids are well vaccinated and there's a large number of vaccinated children, they will reduce the transmission of those serious disease. And because there's a number of co-infections, it could be either with influenza or it could be bacterial infections like pneumococcal disease, that could help reduce the burden in the population overall. Next slide. So then we turn to the question of what is needed for national recommendations. If we know that it's important, how could we get high uptake? Next slide. So we conducted the research that I mentioned in those 34 countries, and we asked them about what are the things that facilitate a decision about a national vaccine program for older adults. So not surprisingly, at the center, you're seeing disease burden data. Just about every country wants to see that. But some of the other things that facilitate decisions are also important. So making sure that we have economic data, making sure that there's surveillance programs to not only detect disease, but also look at the impact of the vaccines. We want to also make sure that there's experts in adult immunization on the technical advisory committees. Oftentimes they're made up of people that have a pediatric focus, and bringing in those experts that can consider the questions that are specific to older adults can be very important. Looking at the policies, whether there are adult vaccine policies and healthy aging policies is also important. And then stringent requirements for adoption. And what I mean by stringent requirements is some countries require things like tech transfer, or that vaccines be made in their particular country, or that studies happen in their particular country. All of these can slow down vaccine decision-making and adoption, and are things that need to be considered when there is a crisis like this. And then finally, the health security focus was something that emerged very strongly as a facilitator for adult immunization programs and their decision making. And that's when countries have seen previous crises like the H1N1 2009 pandemic, or tsunamis in Japan, or other natural disasters that have helped driven decision making and moved it forward. Next slide. Turning to factors influencing implementation of programs, you can see these here, and some of them are obvious, like financing of vaccines. If an adult has to pay out of pocket, it it's less likely that it's going to happen. Making sure that you have the right messaging and that it's coming from champions can also be very important. But other things like registries, how are we determining who has been immunized and who hasn't been immunized is also important. And the use of that data, so if countries have particular targets that they can achieve, we found that countries that use that data and manage the process more carefully are going to be able to ensure that there's a higher number of adults that are immunized because they're assessing and they're adjusting. Things like access are also important. Where can you get the vaccine and how easy is it to get the vaccine? Some countries allow pharmacies to immunize, some countries don't. Some have a very convoluted process, so it's difficult for the older adult to get the vaccine. Generally, we do find, though, when a health system is centralized, that there's a greater chance that the vaccine recommendations will be followed. Now, that doesn't necessarily mean that the country needs to be centralized. Like, for instance, in Australia, it's actually quite a decentralized system, but it's centralized promotion and centralized monitoring that enables the country to achieve high uptake. Next slide. So taking all of this together, what we did was we took a look at how are countries performing and do they actually meet these criteria that we're talking about? And one of the things that we discovered is that one size really doesn't fit all, that success can come in many different ways. So next slide. What I'm showing here is what we're calling an archetype analysis. So there's a couple of elements that, that you're seeing here. First is that we're taking a look at program performance. So we're looking at program performance on a decision-making scale as well as implementation scale. And we had used a database of countries as well as key informant interviews with people within the countries to be able to determine how well did each country perform on criteria. So we mapped them out here. The second element that you're seeing, though, here is archetypes. And that has some degree of relation to performance, but not entirely. This refers more to what are the approaches and what are the priorities that certain countries are taking that characterize how they go about achieving the success that they achieve. So what we discovered is that there are 4 different archetypes. That we have a disease prevention archetype, which is characterized by a focus on data. They generally have strong processes, so they're taking a look on a regular basis as to what vaccines they should be adopting or not. So you'll see that all of the countries in this archetype do perform very well on decision-making scores. There's a lot of variability, though, to implementation, and there's a lot of different reasons why that is. But the thing to remember here is that a lot of these countries are process-oriented. The thing that the second archetype was the health security focused archetype. These were the countries that we found that decisions and strengthening of the system had been driven by some event in the past. Oftentimes it was H1N1, but sometimes it was outbreaks, sometimes it was migrant crisis, a number of different things that could cause a country to move forward. And that's not either good nor bad. It's just explaining why these countries were making different decisions and what a motivator was. And understanding those motivators is what could be really important in focusing on what should then be done next. But the thing that you see here is that there's a lot of variability in performance. And that also you'll note that certain countries could belong to more than one archetype. So for instance, the US could just as easily be put into a health security archetype, but the primary driver there is the process. Now, the thing that we're concerned about with the health security archetype is how short-lived some of the decisions are. So it may be that there are things that are done in the moment in crisis. Question is whether those investments are sustained. Then there's another group that involves the evolving adult focus. These are groups of countries that may already have stronger childhood immunization and are starting to really focus on adults. They haven't yet reached the point where they put in the full emphasis of what they could for adult immunization, but there's a lot of promise there in these countries, and building up some of their systems and programs could show a stronger adult vaccine focus. And then finally, the last archetype is the child focus archetype. And what we see with these set of countries is that the focus still is on implementation of their childhood program. That's where a lot of the resources are going, and effort to ensure that rates of immunization are increased in their childhood program. Again, it's not an indication of doing well or poorly of their childhood program. It's more of an indication of how much of a focus older adults are for that particular country. Next slide. So there's things that we can take, lessons that we can take away as to what might be important for COVID-19. And we think that they do depend somewhat on archetype. Like, for instance, in the disease prevention archetype, you're still going to need to make sure that all the elements are in place for decision making. But some of the things that may warrant an increased focus is looking at delivery, and how can we ensure that with current vaccines that you can deliver those safely, because we know with COVID-19 it's going to be a challenge to maintain social distancing in many settings where vaccines are already given. So what can we do that's more innovative to look at, like things like drive-by campaigns or direct-to-patient delivery, or things that create a new workforce or also create jobs? In the health security archetype, it's also countries that are largely driven by a crisis. So things that are important there are going to be to manage expectations, to make sure that there's good communication, and that there is adequate supply to meet the demand. Something that is going to be tricky when it comes to older adults, particularly as the vaccines for older adults may or may not work in that particular age segment. And in many of the countries, there will need to be some type of prioritization about who gets vaccines and who doesn't get vaccines. An uncomfortable decision, but it's one that is a reality. So for evolving adult archetype, we may want to focus on some of the broader values of older adult immunization, things that go beyond the particular disease and keep an adult healthy. Things like that flu vaccine has the potential for reducing risk for cardiovascular events or stroke. And then finally, in the child-focused archetype, it's important to continue to boost childhood immunization rates, because that's how we're going to get the community immunity effect. But we also want to look to synergies to offer other services. So again, their focus may not be older adults initially, but perhaps there are opportunities to think about what can be done. Next slide. And then just a couple of comments about LMICs, or low and middle income countries. Few have adult immunization experience. They do generally have younger populations, but they do still have older adults. So this means that the bar is going to be higher in low and middle income countries. They do have burden there, and we need to be thinking about what can be done to protect people that are living in countries that have fewer resources. Can things be done differently? can we be planning differently and understand some of the differences in epidemiology? For instance, an older adult may be somebody that's, 40 or 50 years of age. It may not be somebody that's, in that 80-year age group or not. Surveillance may be limited in those places, but we also have to understand that they do have a lot of experience with outbreaks and some success stories with Ebola and meningitis. They're thinking about universal health coverage, so that's generally treatment focused. We need to understand what that actually means for older adults. And then the final question is, will older adults also access the same system as children do? So in summary, some of the things that are most important is that we do have existing vaccines and we can help. And now is the time to start strengthening those systems to make sure that when we do have a COVID-19 vaccine, that we can use that to make sure that we're getting good implementation and decision making. We do need a better contribution, better understanding of the contributions that older adults give, older adult vaccines give. And those contributions need to be understood by decision makers, providers, and the public. There's different priorities of countries, and they do require different approaches, and that we do need to be thinking about this and planning for older adults right now. So I just wanted, next slide, I just wanted to thank Prar for her contributions to this work and for people coming with their comments and questions, and we'll open it to questions right now. So, so there's a question here about what I meant by the primary driver is the process, and I meant primary driver of the process, but what that means is that different countries take different approaches, and what motivates them most would be the primary driver. And then there's another question about going back to the previous slide, but I'm not sure what the previous slide was.
Lois, am I able to ask a question?
Yes.
In low-income countries, often the focus is on childhood vaccination and increasing the coverage for childhood vaccines. Clearly with COVID-19, we're in a situation where suddenly everything is upturned and we're concerned not only about people with comorbidities, but the aging population or the older population. Do you think that there is perhaps an opportunity to engage lower income countries in adult vaccines more broadly because of the focus with COVID?
Yeah, and no, a great point. I do think that there absolutely is an opportunity to engage low income countries. Just because they don't have the resources now or that their focus may be elsewhere, I think with this current context, we need to be thinking about all the tools that we can use and what is going to work. One of the challenges with some of the lower income countries, and not all of them, is that some of them have very high rates of childhood immunization. So the thought is that maybe you'd get some type of community immunity or reduced transmission. So there's less disease circulating, and that might be an approach to protecting older adults, but some of them don't. And so you may need to be looking to what you can do to protect older adults. I think it needs to be realistic, and it's not something that can happen overnight, but the countries themselves can be involved in the conversation, and it's really important to start to engage the people that are seeing the burden and understand their health system, because what's going to work in one country may not be the same solution in another country. So another question is, what is the current status of testing clinical trials for COVID-19 in older adults? So that's It's a great question, and there's an amazing amount of new vaccine candidates out there. But one caution I'd put is that there is still at very early stage testing. So we don't know how well they will work in older adults. So we know that there's over 100 different candidates out there. There's 6, I believe, that right now are either in phase 1 or phase 2, which means that the phase 1 that they've taken the safety testing, which they would not do in, there's a cutoff age, so they wouldn't do that in the oldest populations, but generally healthier, younger adults. That will happen soon. As far as large clinical trials, I think time will tell on that one. Next question. Thanks, Laura, for this question. How do we advocate for adult vaccination and life course vaccination as a priority for preventive health in low and middle income countries when public sector's funding is already too constrained to ensure annual immunization operational funding for delivery, not just vaccine costs? And I think that is the million-dollar question. So great question, Laura. The interesting thing is that in some countries, and this is something that we've learned, it depends what their perspective is, and it depends how they manage crises in their population. So I think that in some cases, you will find that the fact that there is a crisis out there, that you may find some countries that are able to get either additional donor funding to become prepared. And remember that, you know, life course vaccination is something that's supported by WHO. It's supported by all sorts of organizations and agencies. So donors do have a desire to help. And I think that's also important. So, you know, I think it's not fully answering your question. I think it is going to be a challenge to work in a constrained environment, and we have to be realistic, but also look at comprehensive approaches. You know, it's not just about vaccines, it's about how good is your testing, how, you know, what is the structure of your health system. So there's many intertwined considerations that need to be taken. So the next question is about, would there be any more publications on this subject? And the answer is yes, and any day the publication on the full study that I presented is going to be published in Vaccines. So we've gotten the final proofs back, and I can send out a link to everybody when that actually appears. So it should be any day now. There's also some other things that are being published about adult vaccines. Some of the other work we're doing through the International Council on Adult Immunization is presenting a roadmap. So adult vaccines is a complicated topic, and it requires a lot of different partners, and many of the partners that are here today on this call to be able to the partners that are on this call, to enable them to move forward in a way that makes sense for everybody. Because remember, it's a life course approach. It's not about, you know, making sure that we just have solutions that work for the older adult population, but we have to make sure that the solutions work for the entire population and work for the country. So there's a lot of consensus building that will be needed. There's also a lot of thinking about new strategies, particularly about delivery. So that's the one that I think weighs on me the most in some senses, because I think we have to start rethinking, how do we deliver vaccines? And this isn't just an issue for older adults, but when you can't have close contact, I think we need to be prioritizing some of the different types of formulations, like skin patches or maybe oral formulations that enable vaccines to be delivered in a different way, and perhaps by a different set of people. So those are some of the things that are coming up. So which countries are doing a better job at tracking unimmunized adults? And how does this work? Do countries with universal health coverage do better? So let me take the first part of that question about, there are some of the, and in particular, it's not necessarily related to income, but there are some countries that do better than other countries in tracking older adult immunization. So, but some of those countries include mainly the UK, and UK is probably one of the best at tracking which patients have actually received vaccines. And the reason I'm saying that is because what they've done is they track it in individual patient level. So the family provider is going to be sending letters out to the individual patients to make sure that they have their flu vaccines. And then it comes back to them to know how many of those patients are being immunized. Now, there's another element in there which also helps, which is incentives. So the more of their patients that are being immunized, the better. But it's that centralization that is a unique feature. There's also some experience in Australia that we're noting that does a very good job of, in a decentralized environment, still capturing how patients are registered, whether they're immunized or not. If you look to here in the US, one of the challenges is that we have a very fragmented system for older adults. So as many of you know, it could be that you belong to all sorts of health plans, and different health plans don't speak to each other. So you know, the way that we know about coverage is through different types of surveys, you know, to find out the level of immunization for various people. And then we can look into various health plans and get those data there. But there's a lot of variation to what actually works and what doesn't work. Let's see, the next question is, when the first vaccine becomes available in a country, there's likely to be a substantial shortage. And yes, that is very true. How can we ensure that the poor will not, and the most vulnerable will have access? And that is a great question. And I think it's a really important question, why it's crucial for all countries to be sitting at the table together to define what is really the criteria for prioritization. What we don't want to see, and what benefits no one, is if all the vaccine goes to the places where, it's not to say that people need it the least, but if it goes to places where there isn't the greatest burden, then we have to be thinking about whether we're actually protecting the world or not. So again, they're really complicated questions, and I think it requires getting a good understanding of what the needs are in various populations and ensuring that the people that are greatest risk for severe outcomes are receiving the vaccine on a more equitable basis. You know, again, something that is not easy, but the other part of it is getting a sense about what the demand is right now and what the demand is likely to be in a year or 2 or 3 now, because we do need robust demand forecasts. So if there was one thing that I learned through my experience with the pneumo ADIP in particular, was that when you can communicate the assumptions behind the demand to the manufacturer, they're more likely to take risks. It's something that we need to take shared risks, and manufacturers are stepping out there. They know that there's a certain amount of vaccine that will be needed, but the volume of vaccines could vary anywhere from tens of millions of doses to billions of doses. So if you're vaccinating everybody that is eligible for vaccines, that's something that even with some of the great vaccine demand that we have today, that we still may not be able to meet. So that process needs to happen. Next question is, are there any lessons that developed countries can learn from LMACs on vaccines? And I'm so glad that that question was asked, because that's a great question. One of the things that, and this is just one example that we've been thinking about, is that one of the things that I think LMICs have done very well is looked at how do they use their community health workers. So community health workers are people that maybe don't have the same level of education as a doctor or nurse here in a developed country, but play a really, really crucial role in building vaccine confidence, in getting people immunized, and looking at the resources that we have differently. So I think that is just one example, but there's many, because I think we have a lot of ingenuity and a lot of great examples from country to country. Now, the challenge is taking countries that have similar challenges and looking at them in different ways. Next question is, has anyone compared investments in adult vaccines versus other interventions to prevent morbidity and mortality in older age groups? And that's a great question, because a lot of it is all about resources. And I think the challenge is that there's a number of things that could be done. And I think that has been done for specific interventions, but across the board, I'm not familiar with research that's been done in that area, but that doesn't mean that it hasn't been done. I think the challenge is making sure that we get a bundle of interventions and a balance. So things like, if you're comparing influenza vaccine to interventions that would help prevent heart attacks, that probably wouldn't make the cut. But if you're thinking about it as a bundle of interventions, to make sure that cholesterol is being lowered, that there's interventions for, healthy living and diet and exercise and things like that, then it becomes a different story. And I think we need to start looking at how do we address older adults more holistically, because it's not a single intervention that would be important. It says, does any country have an adult vaccination card like a child health card? I just had a difficult experience accessing my own recent immunization record in the US. And I get that. I have that issue as well. So there are the adult immunization cards, and they're generally travel cards. And there's also cards that are used electronically. So those records, that does exist in a number of different countries. Whether it's an actual paper card, I'm not sure about the answer for that, but that's a good question. Next one is, in so many countries, the burden of disease of pneumonia in adults still pressuring the health systems, although coverage in children in some of them is high with pneumococcal conjugate vaccines. What would some of your recommendations be in that case? So that's another really good question. I think the recommendations are twofold. First, we need to remember that there are pneumococcal vaccines for older adults. So there's the polysaccharide vaccine, and then there's also the pneumococcal conjugate vaccine. So those are not widely used as much as they should be. And being able to get the immunization rates up for those vaccines is particularly important. And then in the context of COVID, the thing that I think we need to be thinking about is that there are co-infections and bacterial co-infections. So a recent study, we saw that as high as 20%. Now this is a small study, but as high as 20% of COVID cases severe COVID cases had bacterial co-infections. And I would imagine that a large percentage of those might be due to pneumococcus. So we don't know what the percentage is, but that's one thing that makes sense. So there's a lot of reasons why you would want to prevent bacterial infections. You want to prevent pneumonia, you want to prevent influenza. And then at the same time, taking the strategy to get up the coverage in children, because we do know that children do have an influence on the burden of disease, which affects older adults. So that's something that we need to continue to hammer home to make sure that children are continuing to get immunized. And then, of course, it's not all about vaccines, but making sure that we're taking the appropriate protections that we can to physical distance, to make sure that we're using protective measures wherever possible, and detecting cases as early as possible. So in the case of COVID, it's going to be about ensuring that we know who is been afflicted with an illness and who are their contacts around them. So that will be a really important strategy. So I think I don't know if there's any other questions that I missed. There's one more. Do we need targeted approaches in developing vaccines for the elderly, such as novel adjuvants? And thanks, Bill, for talking about this. So immune senescence, and that's a terminology that means that as we age, and it's a natural aging process, our immune systems begin to decline. So as a result, the vaccines are going to work less well in older populations unless immune senescence is addressed. So some of the ways that has been addressed is through use of adjuvants, use of high dose vaccines, and another way
Hi everybody, we seem to have a technical issue with sound. I'm not sure if you can hear me. So we're just trying to sort that out, if you'll excuse me. And Lois, if you can hear us, we've lost sound from you, so we're going to try to sort that out and re-establish connection. Thanks, I'm getting messages that people can hear me. I just want to say that I've been really impressed by the high quality of the questions. It's a great discussion. And it's an important topic, a topic that I think overall gets neglected by the vaccine community, and to some degree understandably so, given the historical focus on high mortality from infectious diseases in childhood. I'm speaking here as a pediatrician, it's my natural focus. But clearly there are additional burdens of disease and mortality. I think one of the key messages also is the deconditioning that occurs with intercurrent illness events in older adults, not even the elderly, just adults and older adults. One area that hasn't come up, and I was going to ask a question, hopefully we can get Lois back on, is the idea that infectious diseases predispose to non-infectious outcomes, to negative outcomes as well. So recently there was an important paper in the New England Journal that showed that recent influenza illness increases the risk of acute myocardial infarction, in other words, heart attacks in older adults. And so potentially prevention of influenza could have those flow-on effects as well. Lois, I can see you back on, but you're muted. I'm not sure if you can unmute from your end. I'm going to try to unmute you from my end.
I'm unmuted now, so sorry about that.
Thanks, everybody. Thanks, Lois. Carry on.
So I'm guessing that you answered the question, finished the question that Bill had asked.
I didn't fully finish this. Please, if you could go back to Bill's question, and then also perhaps speak about the way in which prevention of infection can have flow-on effects in non-communicable disease.
Okay, so going back to Bill's question about different type of strategies. Yes, there are going to probably need to be specific strategies for adult vaccines. So we don't know that every vaccine will work in older adults, and it's been a challenge for different vaccines, but there have been successful strategies with novel adjuvants, high dose vaccines. And the other thing that I was actually mentioning, one thing that could be interesting is whether it could be delivered differently, maybe intradermally, that might help in the case with adult vaccines. So I think the developers will need to be thinking about different strategies for older adults, and maybe it requires different schedules. We don't know those things, but it is particularly important in that population because they have the most severe effects to be able to address older adults in different ways. And then I don't see the other question. So maybe you could read it.
So I think I'm just going to take the conch and say for a final question, maybe, the recent evidence we saw in New England Journal, I think it was late last year, the important role that influenza might have in precipitating cardiac events in the elderly, for example, and burdens of disease that might not be counted as influenza, but that are attributed to by influenza. And I'm wondering if you could kind of go back over the question of deconditioning in that graph that you had and speak to this issue of flu vaccines to reduce non-communicable disease also.
Yes, okay. Andrew, can you put it back on the one that has the build? So the concept here is that, keep going back. It's with the little stickman. So the concept here, and this actually only shows part of what's going on. We have another graphic that shows a full story in the context of COVID-19. But what we're looking at is that there's a lot of things that are going on when somebody has a vaccine preventable disease, such as influenza. There's a lot of inflammation going on, and there's a lot of reasons why when an older adult sees an vaccine preventable disease, they may not recover as well as we might expect them to. So what that New England Journal of Medicine article showed is that the risk of cardiovascular disease, and it's also been shown for stroke and shown for other diseases, is that it is greater. So if you can make sure that you're recovering better, that process hopefully will lead to an improvement in your risk profile for that next event, which may or may not be another infectious disease. So it could be something like cardiovascular disease or stroke. Does that answer the question?
Sure, thanks a lot. I think we're sort of out of time. Thanks everybody for a really fantastic discussion, and Lois, of course, for a great presentation. Again, yesterday I made a plug for the voice tool, and if it's useful for you, then please advocate for its use more widely. I think the same thing here. We're trying to this week bring up issues that perhaps are not always thought of in the vaccine world, and particularly adult immunization is now more topical than previously, but previously kind of a neglected disease, neglected burden. So do think about these issues. Do communicate with us your thoughts on them. We're very interested to hear more. Lois was instrumental in setting up the Council of Adult Immunizations, and access to that information on that will be available through the IVAC website. So thanks everybody. Tomorrow we have a really important discussion about how to maintain vaccine systems in the face of the COVID pandemic and responses to the COVID pandemic. Obviously we are all highly concerned that the harm from COVID will be just as much or perhaps even more from non-COVID related disease than from COVID itself, and that balance, getting that balance right will be important. So I look forward to your participation tomorrow. Thanks for those who've been with us this week. I know how busy it is for everyone at the moment, and we really value your participation. We're learning a lot from you, and we hope that you're also gaining benefit from these sessions. So I'm going to close and thank you all, and hope to see you again tomorrow. Thank you, Lois. Thank you to all the participants.